Oh, sorry. We're at 45 attendees. Good afternoon, everyone. I'm unmuted now. Beg your pardon. All right, good afternoon, everyone. We're at 50 people now, so I think we can start. I am Caroline Stein. I'm one of the hematologists at the UFS. For those of you who don't know me, good afternoon. We're going to be presenting an update in Mantle cell lymphoma this afternoon. Dr. Amar Dowd will be leading us in the discussion. So just want to advance. Thanks. So yeah, today's deep dive is brought to you by the UFS and Blood SA in partnership with SACHAS and SACETS. Once again, a sincere thank you to the management team of the Deep Dive program, Prof. Berg, Dr. Kritzinger, and Dr. Smith. Without them, we wouldn't be able to do this. Just some housekeeping notes. Again, please note that the recordings of these sessions can be found on the Blood SA website under Resources and Deep Dive. They're easily visible and can be accessed at any time. Please do feel free to add questions or comments in the chat box so that we can discuss them at the end of the presentation. Please note that for CPD points, in order to be eligible, you need to ensure that you're attending with your own Zoom link and not in a group. You need to attend for at least 1 hour, and please do also check that your HBCSA number is entered correctly when signing up for Deep Dive, and these points will be submitted for each attendee. Please note the email at the bottom for any queries if you'd like to contact them. You can join the mailing list via either the website, resources and subscribe, or use the QR code shown on the screen. The feedback from the sessions is extremely valuable, so please do complete the survey at the end of the Zoom meeting, which will come up automatically. So today's agenda is updates in mantle cell lymphoma that will be presented primarily by Dr. Amar Dowd. We will after that we'll have some Q&A and closing. Just an introduction of Dr. Dowd. He is a clinical hematology fellow at the UFS, having joined our department in 2024. Dr. Dowd completed his undergraduate medical training in Sudan and went on to specialize in hematopathology at the University Malaya in Kuala Lumpur. He obtained his degree in Hempath in 2012 and thereafter returned to Sudan, where he worked at the Garden City Private University and was promoted to Associate Professor of Hematology in 2022 and then joined us in 2024. So Amar is a valuable member of our team, and we're grateful to have him on board. We're looking forward to his talk. And then just in terms of next week's session, it will be presented by Dr. Lucille Singh, a very interesting topic, detecting the PNH clone and other hematological conditions. So we look forward to that. Okay, thanks. I'm going to stop sharing, and then Amar, you may share your slides. All right. We can see your slides, Amar. They look good.
See, okay. Yeah, good afternoon, everybody. Today, as Dr. Caroline, thank you so much for your introduction. I'm going to talk about mantle cell lymphoma. Just a little bit of historical perspective of mantle cell lymphoma, which is, is described by Leonard 1973, which is around 50 years ago, is not so old disease, as a centrocytic lymphoma, and then was identified as a separate disease in 1980s. From that time, the WHO added it to the classification in 1994.
Just pass the slides on there, because the slides aren't moving, so you just need to pass that.
Yes. So I'm just going to talk, I just share my slides, move my slides. My presentation components will be about an overview of mantle cell lymphoma, including historical backgrounds, incidence, biology, and heterogeneity, clinical products, including the indolent versus aggressive, and we are going to speak a little bit about the evolving landscape and ongoing challenges and future direction of mantle cell lymphoma. So, historically, as I said, mantle cell lymphoma is described 52 years ago by Leonard as a centrocytic lymphoma, and then identified as a separate disease, separate entity in 1980, and added to a WHO lymphoma classification in 1994. So also historically, if we see here, we have two graphs representing the survival incidence of mantle cell lymphoma, which is a relative survival rate, and by two lines. One line is representing the solid line, is representing two periods. One is 2000 and up to 2006, and the other is from 2007 up to 2013. We see how this disease accumulates around the keep on increasing in this broken line, keep on increasing, and mainly at the elder age group. As well, if we see here, this is the incidence trends of mantle cell lymphoma from 1992 up to 2004. We see how the graphs here is rising. This is a comparison with other non-Hodgkin's lymphoma, and we see how stage 4 is, how the disease is rising, and especially the advanced stage of the disease. This have many explanations. So what is mantle cell lymphoma is one of the non-Hodgkin's lymphoma and represent around 5 to 7%, with the age adjusted around 1 per 100 million cases. And the median age is a disease of elderly, mainly median age is 68 years of age. Commonly tend to concentrate in male, very interesting. And commonly we can find it in the lymph nodes, the bone marrow, as well as the extranodal sites, and can be also in the extranodal sites without the lymph nodes in a few percentage, up to 14%. It occupy usually, when it arises, usually will be found in the mental zone, but this is not a universal feature. We can find it in any other site other than the mental zone. And commonly it is a heterogeneous type of lymphoma, both indolent and aggressive type. And this is why it have a peculiar types of presentations. Historically, is considered an aggressive types and incurable lymphoma. And recently, people start to understand the biology behind mantle cell lymphoma, and accordingly, many effective and targeted strategies have been developed, as we will come to see. It tends, nobody knows the etiology, still not known, but it tends to cluster around families, which is reported in some of the literature. How this disease is developed, usually is derived from the naive B cell, and it can be discovered accidentally in 10% of cases, and usually tend to progress. So it's developed from the naive B cells or from the memory cells. And then what is happening is that this disease tends to have a mutational changes in a form of translocation of chromosome 14 with chromosome 11 at specific site, and this is representing the immunoglobulin heavy chain and the CCND gene. The CCND will come in close proximity to immunoglobulin heavy chain, and usually at the promoter area of it, which have a tendency to accelerate the activation of CCND1. And this will result in two types of disease. First, it represents around 95% if this mutation occur, but sometimes this mutation in 5% of mantle cell lymphomas, this mutation can be negative. So the translocation may occur, but occur with cryptic mutations. And this process will lead to drive this mutation, lead to expression of cyclin D1 protein, and this cyclin D protein is responsible for activation of SOX gene or SOX transcription factor, which is responsible for the activation of the cyclin D1. And cyclin D1, as we know, that it is one of the cell cycle regulator proteins. These cell cycle regulator proteins will lead to usually will be phosphorylated, lead to phosphorylation of B27 and the retinoblastoma genes, and this will lead to increase in the cell proliferation, especially in the G1 to S phase. So the cells will start to proliferate there. And when the cells start to proliferate, this will lead to a lymphoma, which can stay at its site, and we refer to as an cytolymphoma, or it can progress anywhere. So sometimes these, when it progresses, usually it goes to the what we refer to as a conventional or classical lymphoma with a SOX11 gene positive, and it can progress as well, although it is the aggressive form of the lymphoma, but it can progress and become more aggressive when it is hidden by other or when there is a secondary mutation or genomic alternation. And this is usually happen by different types of gene. As we will come to see, they can be mutated as well, and leading to a second hit, like the Notch gene, Notch1 and Notch2, and TB53 gene. And the third site where this lymphoma can go is to go to the germinal center, where there is unmutated immunoglobulin heavy chain. And this is what we refer to as non-nodal leukemic lymphoma. And mantle cell lymphoma with the SOX gene usually will be positive and unmutated, is hypermutated immunoglobulin heavy chain. The fifth type, which is the more aggressive type, and we refer to as the blastoid types. As I said, the classical types, when it is subjected to another hit, genetic alternation, it can lead to a more aggressive form, what we refer to as the blastoid types or the aggressive mantle cell lymphoma. And this, as we said, it's due to P53, can be due to Notch, 1 and 2 can be due to ATM gene or ataxia-telangiectasia mutations. And all of them, all these mutations, when they occur, they can occur in the post the classical form, and this second hit can be directed to the classical form of mantle cell lymphoma, as well can be directed to the non-nodal leukemic lymphoma. So both of them have a tendency to undergo more aggressive pleomorphic forms. This is the genes that we talk about. They can cause a second hit. Among them is ataxia telangiectasia mutations, which is present around, and then the CCND1, TB53, and the rest of the gene. And those, as we see, they can cause a dysfunctional protein in the DNA repair, in the cell cycle regulation, and can lead to DNA damage or epigenetic pathways. So these different pathways now becomes a target for treatment, as we will come to see. What is the pathogenesis again? What happens during these mutational changes? There is a B cell receptor gene activation lead to phosphorylation of the tyrosine kinases. Among them is protein tyrosine kinase, and then by itself is phosphorylates the phospholipases and lead to release of calcium. This is one pathway which lead to activation of NFAT and ERK and NFKB mutations that are responsible for the cell proliferation and survival. As well, there is another pathway which is phosphatidylindole 3 kinase, and this will lead to activation of mTOR and NFKB, which will lead also to activation of NFAT and these transcription factors responsible for B cell proliferation and survival. This, as we said, it results in three different types of mantle cell lymphoma. The in situ mantle cell lymphoma, which will become mutated, and this is in situ mantle cell lymphoma. As we said, it can be discovered accidentally. Even after the treatment of the lymphoma, we can, or other types of lymphoma, we can find this in situ mantle cell lymphoma in the biopsy. And it can also, it can either become a classical type, which is immunoglobulin heavy chain unmutated with the SOX11 gene positive, or become immunoglobulin mutated with the SOX gene 11 negative. And this gives two types of mantle cell lymphoma, the classical type, and the nodal leukemic non-nodal mantle cell lymphoma. This leukemic non-nodal mantle cell lymphoma, or the classical types, they can be subjected to second mutations and leading to a blastoid or the pleomorphic form and the more aggressive forms. Also, the leukemic non-nodal can be also hit by another mutations and will lead also to more aggressive forms. So, but it is rare to get leukemic non-nodal in an aggressive form also, but it's common also in the classical type to become an aggressive and presenting in this way. So this is just a differential of the how the clinical presentation of the classical one which is worsening in the B symptoms which is highly aggressive types and characterized by excessive proliferation, and this proliferation is represented by the Ki 67% of more than 30%. As well, the in situ usually is low growing and indolent to slowly progressing, is asymptomatic, and the non-nodal mantle as well is similar to chronic lymphocytic leukemia in some sense, and sometimes will be mistaken for the CLL. Is usually indolent and is with a low Ki 67. The classical variant, as we said, it has subclasses, and these subclasses can be with cyclin D positive and can be with cyclin D negative, or can be a blastoid form. And so ranging from an indolent types of to a more aggressive blastoid or pleomorphic form. And this blastoid or pleomorphic form is similar to B lymphoblastic leukemia. And so from here, the presentation as well can present but there is a range of presentations from asymptomatic up to an advanced leukemic-like symptoms. And the asymptomatic usually discovered incidentally, and usually, as we said, sometimes retrospectively can be, some might present in a feature in between, which is the B symptoms, and some might present with GIT, and very important to screen for GIT when you are suspecting mantle cell lymphoma, because the indolent or the can be found in the GIT, but commonly they present with these features with abdominal distension and diarrhea, because and is characterized by a polyps, very huge polypoid lymphomas, and this is the old name for the mantle cell lymphoma that is affecting the GI. The nodal is also can just present with lymph nodes enlargement, or not to forget also when we are screening for mantle cell lymphoma to look for the kidney soft tissues, although it is rare, and the CNS manifestation as well also is rare, but it can occur with mantle cell lymphoma. And very important also the Waldeyer ring lymph nodes and the endocrine and the lungs. And usually in the lung, it resembles the extranodal marginal zonal lymphoma. So when we get the patients with lymphoma, usually we need to assess the patient, and we need to do some basic investigations. Because this is important in the treatment, we need to assess the patient in form of his performance status, and we need to see the symptoms of the patient, as we said, can be, and as well we need to look for the other comorbidities in the cardiovascular systems or the bone marrow infiltration. And then we do a basic investigations, and we do a confirmatory diagnosis by taking a tissue biopsy, and see which should be reviewed by hematology pathologists expert in this area. And we, in the biopsy for confirmation, we need to do a flow, as we will see now what are the criteria for diagnosing mantle cell lymphoma. And the histopathological review should confirm the diagnosis based on the and should tell about if it is aggressive or is a classical blastoid or pleomorphic, because this is usually a pathological description. And we need to do some stains which will help in identifying, and as well can be considered as a risk stratification and help in the management, which is a KI67. And currently we can do also TP53 as a mutational as stain, and we can do it also as a PCR. Also, we need to know the SOX gene as well. Is it a positive or negative? Because usually have some impact on the prognosis. Coming to this, confirming the diagnosis, still we need to do an imaging, and we need to do an imaging, especially CT and PET scan, which can help, as we will come to see, how is PCT sensitive and how and what is the degree of sensitivity in different types of tissue with mantle cell lymphoma specifically. And we need to do, and as well, this scanning can help us in the tissue biopsy. And we need to do the GI screening as well. And there is some expertise. They think that upper GIT endoscopy and colonoscopy should be done for all the patients with mantle cell lymphoma, because this mantle cell lymphoma can be an indolent and can be found within the GIT. To confirm this, as we said, the tissues that we take or the blood that we take, we can do a flow cytometry, and we can do as well a fish screening. And not to forget, for each patient with mantle cell lymphoma, we need to do some genomic testing, which is currently as included in some of the practice. So what are the stains? What are the markers that we are looking for? The positive marker, we look for the pan B cell markers will be positive, and Kappa or Lambda, mainly Kappa more than Lambda, and we can have FMC7 positivity and SOX gene positivity in 90 to 93%, and cyclin D, as we said, which is a driver for, which is a hallmark picture of mantle cell lymphoma, will be 100%. Although there is some cases where we can't find the cyclin D positive, and in this case we need to do, is usually cryptic, or we can differentiate it by doing other tests. What are the negative markers? CD23, although we have some variant of mantle cell lymphoma, also can be of CD23 positive, especially those with a negative cyclin D, as well as CD10 and PCL6 as well can be negative. Usually is negative, but in a few percentage of patients also we can find them positive, especially those with cyclin D negative. So the diagnosis, as we said, is laboratory. We can find lymphocytosis, and we can find some extranodal involvements. Morphologically, we need to assess to differentiate between the pleomorphic, the small indolent types, which is usually have a small characteristic, and the medium type, which the pleomorphic types or the blastoid types. We need to differentiate each of these, and in doing that, we have to do immunohistochemistry, TB53 mutations, Ki67, and flow cytometry. As I said, the imaging is very important, and the tissue biopsy as well, and the endoscopy. So how we benefits from the PET scan? Usually it helps us in staging, it helps in restaging and in treatment response evaluation. Although some experts think that, or some studies like Nordic mantle cell lymphoma 3 and 4 trials, they think that there is a poor correlation between the PET scan after treatment and the progression-free survival. And they think that there is no correlation as well between the PET scan and myth of induction, and in a sense that of the overall survival or the progression-free survival. So it is more sensitive when we have splenomegaly. It is more sensitive when we have a nodal involvement, but it is less sensitive when we have a GI involvement. That's why we need to do a colonoscopy or upper or lower GI. We need to do scope. And is very low sensitive when it comes to the bone marrow as well. Again, after treatment, we need to assess the MRD, and now MRD is become, as we will come to see that most of the new strategies, they adopt this MRD in some of the studies, shows that this MRD may improve the progression-free survival, the PFS, when it is negative, and they use it to direct the treatment, especially the lymphoma groups, which based on this trial, they think that there is a correlation between MRD with the outcome of the induction. And when we do the MRD, the sensitive range for MRD will be 10 to power 4 or 6. And usually we have different modalities by which we can do an MRD. The most sensitive is immunoglobulin sequencing, and followed by the PCR, nested PCR or multiparameter flow cytometry. What are the criteria for the diagnosis? For the WHO stated criteria for the essential markers that we need to look for when we are dealing with mantle cell lymphoma, which is a pan B cell marker, as we said, and CD5. And they think that the classical, we have to report on the morphology and the centrocyte likes or the other variants. And usually they think that it is very essential and crucial to do a cyclin D for any suspected, but it is desirable to do a SOX11 detection. When it is a cyclin D negative, when it is cyclin D negative mantle cell lymphoma, usually we tend to have other variants like the monomorphic variants, and usually the SOX gene positivity. And we have also to concentrate on the microscopic description of the mantle cell as well. We come to a very important area, which is the prognosis of mantle cell lymphoma. And there is many scoring system. There is maybe system, which is a scoring system for mantle cell lymphoma. And this have been validated and using an international prognostic index, or incorporating this international prognostic index with the Ki-67 to become a combined maybe score, or we can use a simple maybe score. But combining these maybe score, the international prognostic scoring system with the Ki-67 is very important and very crucial, because it extends the degree of identification of the high risk and the low risk patients that currently use in stratification of the treatment. Okay. We have, not to forget, we have other risk factors nowadays in the pipeline, which is the TB53. It's commonly used nowadays in the new era of, and is the plastoid morphology as well is used, and the progression of disease within 24 months, and this is usually validated by many of the studies, which think that they have a very high probability of time from BOD 24 up to the death. So this will guide management for the high risk patients, especially high risk patients tend to have these high Ki-67, both 24, TB53 mutation, and plastoid form. So we need to deal with them. If we find each of these, we need to deal with them in a different way of treatment. As well, we need to do an NGS to see if we have any other cytogenetics abnormality. And importantly, one of the high risk features, although it is real, as we said, is the CNS involvements. And when it is there, and when there is a suspicious, we have to do LP to confirm that, and preferably we can do an intracecal as well. Okay, now we move to the treatment, and we have different options for treatment. We have the chemotherapy options, which is the classical and traditional way of treating mantle cell lymphoma. And as we know that all of us that this chemotherapy can be directed to the microtubules, can be antimetabolites, can be topoisomerase inhibitors, and can be alkylating agents. Among them, what are the options that we have in mantle cell lymphoma? We have options for less intensive, like bendamustine, for example, and we need to balance the efficacy and the toxicity as well. We have a more intensive types like the cytarabine, which is incorporated in many of the protocol, and we have the Nordac regimen as well as the Hyper CVAT. So these are the chemotherapeutic agents that we can use, we are using them traditionally in the treatment of mantle cell lymphoma, although some of them is still in the treatment side. The second category that we use the immunotherapy. And as we know that the pioneer of immunotherapy is rituximab, which is anti-CD20 that introduced in 1997. And here is some graph of some of the approvals of the immunotherapeutic agents. And the common immunotherapies, also common regime in which we find these immunotherapies a combination with chemotherapy, like bendamustine and rituximab, which is the main standard of care treatment of mantle cell lymphoma in and the FCR as well. We have Intuzumab as well, which is FDA approved as well. And we have the CAR T therapy that we have, which is now considered in the high risk patients, with all those patients who have not being able to be treated by the protein kinase inhibitor. We have bispecific CAR T therapy as well. And the other group is the targeted therapy. And usually we combine them with the immunotherapy sometimes. And these are the different groups of them. Some are B-cell inhibition, like the PTK inhibitors and phosphatidylindole 3 kinase inhibitors, and we have drug conjugates as well, which is a conjugates inhibitors that affect the mantle cell lymphoma tumors. And we have the bispecific antibodies like glofitamab and the, as we say, the CAR T therapy. So those all can be incorporated with, some of them, is immunotherapy, which can be incorporated with the targeted therapy. And among them, the commonly now approved is ibrutinib and acalabrutinib and zanubrutinib and bertubrutinib. So these are the non-covalent PTK inhibitors, and we use them even if you have failed some of the PTK inhibitors first line. But they have resistance. We have to be aware of the resistance of it, and these targeted therapies, usually there is different mechanisms of resistance. I just summarize here the main resistant mechanism in the ibrutinib, which is a mutation at the binding site. And the main inhibitors in the rituximab is the down regulation of the target. And the main inhibitor of phosphatidylindole 3 kinase is the mutation that change the signaling pathways. And for the CAR T therapy is the antigen escape. The other modalities that we use in other than the chemotherapy, immunotherapy, target therapy, we have the autologous stem cell transplant, and we all know that the mobilization of stem cells and then conditioning, reinfusion, and immune reconstitution, which is a salvage types of management, even in mantle cell lymphoma. And we will see how our treatment will be affected when we. So currently, if we have any patient with mantle cell lymphoma, we need to define the disease, and we need to define the fitness of the patients. This is one of the core things. The disease can be limited, which is stage 1, and it is extremely rare in mantle cell lymphoma. Usually is non-bulky disease, which is very rare to find in mantle cell lymphoma, because we said that majority or more than 70% of mantle cell lymphoma will have an advanced stage disease. Nearly all patients, and usually will be a very bulky disease sometimes. We need to assess the fitness of our patients, the age, and the transplant eligibility, and the comorbidities that may affect. Also, one of the things that we need to consider in the approach for mantle cell lymphoma is the treatment response, because if the patients, and this should be assessed in between the cycles, as we will see now, and we need to have risk assessment, which is very important, because those patients who have TP53 mutations and blastoid type usually tends to be a chemo resistant, or they did not respond to the chemo immunotherapy, and we need to go for other line from the start. So we need to identify them earlier. So what are the core approach in the treatment? We have induction, and we have consolidation, and then the maintenance approach. Historically, mantle cell lymphoma, we just see that if the patient need treatment or not. If he didn't need treatment, those are the patients with low disease burden, with low Ki-67 is less than 10% now, because it's incorporated into maybe combined maybe score, as we said, and the non-nodal leukemia, as well as asymptomatic, and absence of these blastoid types or TP53 mutations. Those we watch and wait. Can be, there is a room for watch and wait, and unless they develop symptoms or progress. While those who need treatments, we separate them into those who have a young and fit and eligible for high-dose therapy, high-dose cytarabine, and those who are old and unfit and ineligible for the high-dose therapy. For those who are eligible for high-dose therapy, we go for high-dose therapy, or we go for R-CHOP, or we go for Nordic regime. And for those who are unfit and ineligible for high-dose, we go for rituximab, bendamustine, and rituximab and bendamustine. And then we go, which is usually this is the induction stage, and then we go for rituximab maintenance, or stem cell transplant for the fit patients, and the fitness, because we need them to be eligible for transplant, autologous transplant or not. So we go for autologous transplant followed by a maintenance for 2 to 3 years in both of them. So this is the old approach that we use in treatment of mantle cell lymphoma. But there is a lot of challenges still remain And can be considered with this graph where we have the different period of time where we have our disease from the late 2006 up to 2011. We see how is the curve going on, and we in the mid 2000 and 2005, the disease is uh, uh, usually become very challenging and incurable, and we need a new approach for that. Usually, an intensive treatment, even with this approach, we tend to have a PFS of 7 to 10 years only, but few are truly eligible for these fits and for the intensive treatments. And the 5 years overall survival is estimated to be 65%. Most of, if not all, of our patients relapse, and we don't have any, we have a very limited efficiency of target therapy, especially for the refractory relapse settings. We don't have much option for refractory relapse settings. So how we improve that? How we improve the frontline treatment? Here I mentioned some strategies that we can adopt to improve the frontline treatment. Among them is usually we need to optimize the chemoimmunotherapy at the backbone. And we need also to put into consideration the new targeted therapy to be combined with the chemoimmunotherapy. And the third strategy that we can adopt is redefining the role of autologous stem cell transplant, because a lot of trials are going on, and to give an answer for all of these. And we need to improve the maintenance therapy as well. And as well, we need to omit the chemoimmunotherapy in some of the situations. And we need to employ the MRD guided therapy, because as we see that from some of the trials, some of the people that may not benefit from, for example, stem cell transplant, and although they are eligible, but still they cannot benefit from stem cell transplant. So we need them to be, yes. So how to optimize the therapy? The chemoimmunotherapy, we need to consider the age, as we said, and this is we consider it even in our old regimen. And we need to consider the performance status of the patients and the biology of the disease. Is it a low or a high risk? And by assessing the Ki-67 or TB53, which will be more objective than the morphological things. And we need also to optimize the dose and the schedule and monitor the response to switch to novel therapy when. We need to upfront go for either the patient will be a transplant eligible or non-transplant eligible. So the answer comes for optimization of the chemoimmunotherapy from two trials, two combined trials of 88 patients, and they receive rituximab bendamustine and rituximab in 92% of patients, they completed induction, and 84% of patients, they go for consolidation with auto stem cell transplant. There is no treatment-related disease in both of the in the induction, and only two following the auto transplant. The median time for these two studies, which is the Dana-Farber study and Washington University studies, is 33 months, and we know that we get an answer that 3 years progression-free survival and overall survival is 83% and 92% respectively. So it means that these studies limiting our use of anthracycline as the upfront line of therapy, which have reducing the toxicity. So also for optimization of therapy, chemoimmunotherapy in ineligible, those with, for the eligible persons, we get an answer from phase 2 prospective multicentral study from the Italian groups of 57 patients that have been followed up for around 86 months. They're using the cytarabine and they use the rituximab at one arm, and they completed their 2 years progression-free survival of 81%. The median survival and overall survival is not reached. So, after follow-up of 7 years, they found that the progression-free survival and overall survival is 55% in the patient respectively. There is no progression after 6 years of follow-up for these patients. And that's why it is incorporated now in some of the protocols, international protocols. We can either use a preferred regimen for the induction, and we can use the less intensive preferred aggressive therapy, and we can use also the less aggressive therapy, depends on the patient, as we said, the patient performance status, the age, and so on. So we can either use a Lyme regime, use Nordac regime, or Maxi-CHOP regime. And the preferred regime for the less aggressive therapy will be the acalabrutinib and bendamustine, and we will come to see how we include this targeted therapy here. So this is for the second strategies that we can adopt to improve our treatments, upfront treatments for mantle cell lymphoma, is addition of target agents to the chemoimmunotherapy. And there is many different studies that show up or support the addition of targeted agent to the chemoimmunotherapy. Among them is the SHINE study, and which use bendamustine and rituximab, and the phase 2 which is using the lenalidomide and the lenalidomide study, or with bortezomib as well. We have EcoCrine study, which using also bortezomib and lenalidomide, and we have the window study that using the targeted agents with the cytarabine containing regimen, and it shows an important and we also have phase 3 trials using lenalidomide and R-CHOP, or versus R-HiDAC and R plus or rituximab plus lenalidomide. We have acalabrutinib plus bendamustine rituximab for 3 cycles, and acalabrutinib rituximab and cytarabine for 3 cycles as well. And we have phase 3 EcoCrine study, and we have triangular study. So I'm going to just talk about one of the main studies, which is usually for transplant eligible, and by adding the PTKI or protein kinase inhibitors, and open label trials containing a huge number of patients, which is around 870 patients, is the 3 arms study containing arm A plus I, which is the investigation arms, and this is the control arm, arm A, and we have I. So in the ratio of the patients is 1 to 1, and we in the arm A we use the standard conventional therapy, which is a chemoimmunotherapy and auto stem cell transplant. And in the arm A plus I, we use the ibrutinib plus immunochemotherapy and stem cell transplant. And in arm I, we use the investigated um, uh, regimen, which is ibrutinib and the immunochemotherapy. We omit the autotransplant. All these groups will they receive their induction immunochemotherapy with 6 cycles, and the median follow-up is 31 months, and the progression-free survival of after 3 years was superior in arm A plus I, which is the arms that using and in arm A plus I, which is 88%, the progression-free survival and the overall survival, and versus I, when we compare this traditional one with the newly added PTKI inhibitor, so we have a high percentage of progression-free survival, which is 88% versus 72%. And this, when they look for the eye, when they compare with eye or the standard arm with the investigation arm, is the comparison is not yet in the published, but there is 3 years failure of 72% versus 86%. Comparison of A plus I, which is A plus I with I, the ibrutinib with chemotherapy, with the stem cell transplant, with the arm I, which is the ibrutinib with the chemotherapy without a stem cell transplant. This is still ongoing, and we didn't get the answer yet. And we see here the graphs of, and the result of this now, because of the 88% or the high progression-free survival in PTKI is added to chemoimmunotherapy, then NCCN guidelines now adopted PTK plus rituximab as one of the options for treatment of mantle cell lymphoma. So continue to that, we have failure-free survival for patients with A plus I versus group A in a selected subgroups of patients with low TP53, as we see here. The great differences between those who are using A plus I versus those who are using the standard regimen. Also, PTK inhibitors now in the European guidelines, and they accordingly divide the patients into fit for autotransplant and those who are unfit for autotransplant. And the younger fit patient, they use the induction regimen, and then they offer consolidation for a selected patients, and then a maintenance with rituximab. Yes, we consider ibrutinib even and the R-CHOP components in the induction, and 2 years maintenance in the place of autologous stem cell transplant. And for the MFIT patients with autologous transplant, we use the rituximab plus chemotherapy combination, bendamustine mostly, and we can offer them with R-CHOP or bendamustine rituximab or rituximab rituximab cytarabines, or we can change it. So we offer them also rituximab maintenance post-R-CHOP induction. We consider rituximab maintenance post bendamustine rituximab. We do not offer rituximab maintenance for those who have are cytarabine outside of the clinical trials. And this lead to approval of the acalabrutinib in combination with bendamustine rituximab for adult patients with previously untreated, not eligible for transplant. This is just also two things to consider. One of the studies that using bendamustine rituximab and cytarabines, and bendamustine rituximab with cytarabine and acalabrutinib, and this is usually leading to addition of acalabrutinib in the intensive frontline chemotherapy in patients less than 70 years of age. And this is our ECOG trials. As we mentioned now, we have different types of ECOG trial. This is 3 arms randomized phase 2 trials. And usually the conclusion of the trial that the addition of acalabrutinib to the standard arm added toxicity without improvement in efficacy, suggesting that acalabrutinib should be avoided during the use of cytarabine therapy. So adding PTK to transplant patient, to transplant ineligible, all those that we mentioned them, the ECOG trials and the others, is mainly for those who are transplant eligible. For those who are transplant ineligible, we have a SHINE trials give us the answer that any transplant they recruit the patients who are transplant ineligible with the age of more than 65 years, and they randomize them into 1-to-1 with bendamustine rituximab with or without ibrutinib. And then they followed up, and the result is that the PFS benefit was seen in the arm of bendamustine rituximab plus ibrutinib, and this compared with the placebo, when compared with the placebo, with the PFS of 80 months versus 52 months, 80 months for PR plus I, ibrutinib, and 52 months for the PR plus placebo. So the overall was the overall response was similar in the two groups, which is 89 and 88, 88.5%. Yes, but the patient who have ibrutinib arm, in the ibrutinib arm, usually they get a deeper response with a CR rate of 65% versus 57%. With the caveat that this study was not powered to evaluate these subgroups of patients. The performance benefits seem to be limited to a better prognostic group, such as low or intermediate risk, maybe score, and untreated unmutated TP53 mutations. Adding to that, this trial also, instead of ibrutinib, now we come to acalabrutinib, and this is a trial where acalabrutinib is approved by FDA with bendamustine and rituximab for previously untreated mantle cell lymphoma. And the trial is the 500 or around 600 patients were randomly assigned in each arm, and usually with 1-to-1 ratio, using acalabrutinib in one arm and without acalabrutinib in the other arm. The overall response and complete response rate was 91% versus 6%, and the complete response rate was 88% with the acalabrutinib arm versus 53%, yes, in the placebo arm. So overall survival was not significantly different. And of note, this study usually shows grade 3 or more adverse reaction in 88% or similar in both the placebo group and the acalabrutinib group. The third strategies that we have to adopt in for improving our therapy is to reevaluate the role of auto stem cell transplant, and this is in the triangle trial. The updated supports the omission of auto transplant in upfront PTKI inhibitors. So if we use PTKI inhibitors, we can omit this auto transplant, and usually this trial is we randomly assigned, as we said previously, and we follow up these patients over 14 years with a median follow-up, and those who achieve superior overall survival is seven years versus 4 years in the arm of ibrutinib group or BTKI inhibitors group. At the other side, there is some analysis that come from Swedish and Danish lymphoma registry of 200 and out of 1,300 patients or 400 patients diagnosed with mantle cell lymphoma, this 273 were mantle cell. So from 2000 up to 2011, they underwent autologous transplant. Those only the 273 patients. And when they compare them, they found that who received this therapy without transplantation, the survival was superior for patients who underwent autologous transplant. So yes, there is many studies that we need to personalize the transplant, not to all patients, but for the patients who have not PTKI inhibitors. This is again a question that raised by Echocrine study EA 4151. This is a phase 3 randomized study which is published by us, and this is including around 650 patients divided into which he as I define the eligibility, not 65, is 71% who are eligible for autologous transplant. The trial allowed any standard induction regimen. Most of the patients, they receive R-CHOP and RD-HAC, and 27% of patients, they receive bendamustine rituximab. All patients underwent maintenance therapy, and they use the MRD negativity as one of the markers for them, and they follow up the patient for 72 months. They found no differences in the 3 years overall survival at 82.1% of patients who receive autologous transplant and 82.7% for patients who did not receive autologous transplant. So with introduction of PTK, we can conclude that with the introduction of PTK and other ibrutinib and other PTK inhibitors can be used in the induction and maintenance or at relapse, most patients can avoid the stem cell transplant, autologous stem cell transplant. And this is the design of the ECHO trials, and this is the arm A, which is rituximab, and yeah. And as we said now, the debates is for the role of autologous transplant can be used for selected patients. The fourth strategy that we use is a chemotherapy-free approach. and the answer come from the window trials and window 1 trials for eligible transplant patients, for non-eligible transplant patients. But for eligible transplant patient, we have here a study, single-arm study phase 2 trial of 131 previously untreated patients with mantle cell lymphoma received either ibrutinib rituximab arm, and they show that 24% of patients they progress and 6 patients died on the study. The most common toxicity among the study is grade 3 and 4 toxicity on arm A, and the ineligible trials, which usually use BTK inhibitor with or without other drugs. The evidence this study or this trial, there is 300 or 400 patients with the age of more than 60, with the age 60 years and older, previously untreated. Median follow-up is 47 or 48 months, and the progression-free survival was 65% for patients who use ibrutinib plus rituximab, and 42% for patients who receive bendamustine rituximab. So we see how, this doublet approach have a very huge impact. And also from SHINE trial, where we include 500 patients, and those are the 65 years and older, and those patients randomly assigned to receive ibrutinib plus bendamustine rituximab or placebo plus bendamustine rituximab. The endpoint was progression-free survival with a median follow-up of 85 months. The progression-free survival was 80%. Was 81 months for patients who receive ibrutinib plus bendamustine rituximab, and 52% of patients who receive placebo plus. Yes, there was no difference in the overall survival. Also, in the chemotherapy-free approach, the first, which is answered by these trials, is the doublet approach, but we can also have a triplet approach where we use 3 types of different chemotherapeutic agents, like non-chemotherapeutic agents. And usually this is for the patient who have a high risk, like the blastoid or TP53 variants, because as we see that, why? Because the TP53 variants, the outcome is studied in mantle cell lymphoma. One of the studies, they found that the median progression-free survival is less than 1 year. And when we combined BTK inhibitors with immunological agents, it will be applicable and may lead to an improvement in the therapy. As well, we can consider autologous stem cell transplant, or we can send them for other trials. So this is a phase 2 trial, included 25 patients with TP53 pathology, and they receive zanubrutinib, which is a BTK inhibitor, obinutuzumab, which is anti-CD20, and venetoclax. So they receive a triple therapy with a median follow-up of 28 months, and the overall survival was 96%, and the complete response rate was 68% at the start of the 3 cycles. They didn't complete the rest of the cycles. So at the 3 cycles, this is the trial, and the 2 years progression-free survival was 72%, and the 2 years overall survival was 76%. Also come the answer for the triplet from the OSIAS trials, which is a prospective open-label multicentral trial, phase 1 and 2, done in 5 centers, and this designed to assess the safety and tolerability of ibrutinib obinutuzumab and venetoclax. Those patients were enrolled. 48 patients were enrolled for a study in this period, and we see the patient who lived is 100%, and the patient and the progression-free survival, yes. Yeah, again, this is using other targeted other than the ibrutinib, brentuximab, ibrutinib, venetoclax, and obinutuzumab. We can use rituximab and lenalidomide as a target, and this study usually, which is a mantle cell, those are 38 patients with mantle cell lymphoma that requiring therapy. And this is a single arm study where it include phase 3 still non-Hodgkin's lymphoma trial. This is a subgroup of the trials. They show the progression-free survival of 70% at 5 years. And again, Lyme study also, they compare the R-CHOP with the lenalidomide and rituximab. The fifth, before the last one, is the optimizing the maintenance therapy. And we know that these the triangle and the SHINE versus ECOS trials, usually they think that we need to do a PET at day 100 after transplantation for patients who remain in the complete remission. We proceed for maintenance. Who remain, we proceed for maintenance therapy, and some experts directly go for maintenance therapy without a repeat. So this is the expert ideas. So meta-analysis of randomized trials of 6 trials, including around 860 patients with using rituximab. They pull all these patients and they see rituximab maintenance compared with observation, and the progression-free survival with rituximab in each of the trials and in the pool is the hazard ratio of 0.58%. The risk of neutropenia is higher in the maintenance compared with the observation, and none of the trials report on the quality of life outcome. Grade 3 and 4 is 7%. This is a trial, and this is a design. The last strategy, which is employing the MRD, and we know that MRD can improve the strategy, and many, as we see from our trials, we use MRD to improve the therapy by using either the next generation sequencing or using real-time PCR or NGS for mantle cell lymphoma. One thing to mention is when we have a high-risk trial, when we have a high-risk mantle cell lymphoma, those who are patients with TP53, we need usually to have a different approach for them. And this is answered by bovine study, which is a 2-year study in which patients are using those are the patients that using PTK inhibitors and PCL2 inhibitions, which show a synergist, and in addition to obinutuzumab, and the conclusion of the trial that this bovine is well tolerated as an outpatient regimen and associated with a high response rate and a high rate of undetectable MRD of the treated TP53 mutations patients. So with TP53, with any newly diagnosed patients, this means we can do upfront TP53 mutation status. If he's indolent, we observe just, and if he tends to have TP53 mutated, then we go for, if we go for chemoimmunotherapy, this is an old regimen, and which usually they tend to have, they don't have a response with chemoimmunotherapy if they are mutated. So that's why we go for induction with a novel therapy, BTKI inhibitors, BTKI or proton kinase inhibitors, or venetoclax or others. And for those who are non-mutated, we go for chemoimmunotherapies as upfront, followed by maintenance or autotransplant. Just a few points about the what is coming up is Pirexacaptogene, which is a cellular therapy that studied by Zuma trials of 68 patients with refractory relapse mantle cell lymphoma of more than 18 years of age. So with an ECOG performance of 1 and 5, less than 5 prior therapies. The primary endpoint was overall response rate, and it was found to be 93%, and complete response was 67%. Of the 28 patients, they initially start the study, 43 patients of them is still in a remission for more than 2 years later, and no any new safety concern were observed, although we know that the cellular therapy have some neurological problems. So this is the British Committee guidelines for those who need, who are eligible for Pirexacaptogene. They have to have a diagnosis with mantle cell lymphoma, with with cyclin D overexpression, and they have no age associated. We can give it for any age, and they have a previous anthracycline, bendamustine, or HIDAC, or any of the immunotherapies or BTKI inhibitors. So those patients with ECOS performance have to be good, and no active CNS disease with no any viral infections. All should be negative, and those should be a candidate for CAR-T therapy. Also in the pipeline is 2 other bispecific antibodies, and there is like golfitamab, which is studied in many of the lymphomas, and among 6 of the patients were mantle cell lymphoma. Those 6 patients whose overall response rate was 81%, with complete remission of 67%, with similar efficacy, irrespective of the BTK inhibitor. The grade 3 cytokine release syndrome and neurotoxicity was seen in 14, is not so much, and 13%. Ebicortumab is also a subcutaneously bispecific antibody, and is studied in non-Hodgkin's lymphoma refractory relapse in 68%, in 68 patients. 4 patients of them with mantle cell lymphoma. The overall response rate was 50%, with complete response is 25 patients, so 1 patient. So grade 3 cytotoxicity is 0 and 4%. This is a promising one. So the therapeutic option for, we have not to forget those with relapse refractory. If they are eligible for trial, we'll go for trial. Otherwise, they have poor response to BTKIs. So those with a blastoid or pleomorphic morphology or TP53, then we go for, if they have these, they go for CAR-T settable. If they are settable for CAR-T, yes, we go for bridging with BTK, and then we go for CAR-T. If there is no if they are not having this, we can go for acalabrutinib or zanubrutinib, TKI, and then we do the PD24, and then we go for CAR-T. We see for the progression of disease, and then we go for CAR. If they progressed, CAR-T will be the suitable and available options. Otherwise, we go for stem cell transplant. Although stem cell transplant with these novel agents now, the use of it become less. This is just mantle cell lymphoma with according to the maybe score, we can use it as one of the options to direct patients to CAR-T therapies. So overall, if we have, in conclusion, if we have a newly diagnosed mantle cell lymphoma, we need to do to screen this patient for fitness, and then we have to define if he have high risk features or not. Then we go for the asymptomatic and physically fit patients with no system dysfunction and low risk. We go for wait and watch. And if disease progress, we go to arm C, which is the symptomatic patients fit. If the patient is fit, then we go to arm C. If the patient is unfit and more than 65 years, we go for the arm D, and in post we can start with trials. Then we go for radiation if it is localized. If not, we go for systemic therapy, and the transplant eligibility for the high risk. It depends on the type of the initiation induction that we use. So we think that predicting the future in mantle cell lymphoma is with MRD. MRD can be used in the induction. At the start, we can use after the induction, and we can use it after the consolidation and the maintenance. This is what is proposed to contribute to patients' outcome. So from here, what the take-home message, this is a heterogeneous lymphoma with complex genetic and driver mutations characterized by high rate of relapse, and careful examination, including while there are lymph nodes and GIT, is important, and risk stratification is important in the management. We can use either of the risk that we need, and but currently some of the risk features, as we mentioned, is not only used in the clinical trials. Many novel agents and many changes in the practice that coming up front. All the strategy of management with many challenges need to be overcome. A new strategy with optimizing therapy, addition of novel agents, exploring the role of MRDs, auto stem cell transplant, and maintenance therapy review. With that, I finish my talk.
Thank you so much, Amar. That was an incredibly thorough overview of mantle cell lymphoma. I think I learned a couple of things as well. I think thank you so much for that. I think Prof. Berg's comment that this is a go-to talk is certainly true. So for those needing to study for exams, and for those of us needing to revise this whenever we're faced with a patient with mantle cell lymphoma, please remember it'll be available on the website. So unfortunately, we basically are out of time. I don't know if anyone has any burning questions or comments. I think the best would be to quickly unmute. Otherwise, I'll just wrap up and wish us all a good evening. But is there anyone who would like to make a quick comment? All right. I'm just going to watch the chat.
A resounding thanks from us. It was great, Omar. And you stopped on the dot of 5:30. So very precise, and definitely something that the fellows will use. And just for, I don't want to speak too quickly on Blood SA's behalf, but we are, and I'm, the team is busy making these type of talks also available on podcast, so that people can listen to it while they drive to work in a traffic jam without having to do the data. And Amar definitely did justice to the material. Everything was crystal clear. Great. Well done.
Thanks. Thanks, Estelle. That's awesome. It'd be wonderful to have this in a podcast form. I agree. In Bloem, we don't drive very long, but everyone else in the country, I think that would be very appropriate. So I think just quickly from our side, lots of take-home messages. I think it's really interesting that the availability of BTK inhibitors may obviate the need for transplant, which has been sort of a mainstay of the treatment of this disease. So it seems to me that sort of my take-home message is, again, sort of put your best foot forward in the sense that when somebody needs therapy, if you've got BTKs available, that would be the way to go. Intriguing about the the chemo-free approaches. I think that was really interesting in the fact that in the high-risk setting, certainly still seems to be an area of unmet need. But yeah, the ability to treat these patients with targeted therapy is clearly the way to go. I'm afraid I'm going to have to close just because we are out of time. Thank you so much again to everyone for attending. We appreciate your attendance here this evening, and please have a wonderful week further. Thank you.
Good evening.
Okay, bye-bye everyone. Evening.